All right. Well, good evening and welcome. I'm Dr. Larry Patterson. I'm an ophthalmologist in Crossville, Tennessee, with Eye Centers of Tennessee. With me tonight, we've got Mitch Jackson. Mitch is up in Chicagoland. He's a board-certified ophthalmologist specializing in cataract and refractive surgery. He got his MD from Chicago Medical School and went on to Columbus Hospital, did his residency at the University of Chicago Hospitals. And currently, he's the medical director of Jackson Eye, and also a clinical assistant at the University of Chicago Hospital. So, welcome, Mitch.
Hey, Larry. It's good to be back.
What we're going to do, is we're just going to this is going to be very informal. I've got a few questions to ask you. We're going to be talking tonight about the light adjustable lens, and as is often the case, these are things I'm familiar with, but I've not actually done them myself. So I've got some real sincere questions I'm going to be asking you. So we'll just jump in. This, by the way, is being streamed on several different platforms. So we'll be here, Facebook, Instagram, places like that. And this will be available later for the audiences. So let's just jump in. Tell me what in the world the light adjustable lens is.
Well, the light adjustable lens actually really changed my practice. And so I always define the light adjustable lens, LAL, I'm going to call it. It really just delivers really good, superior outcomes, the quality of vision. And so what is it? It actually is I use 4 words when I describe it: adjustability, invisibility, customizability, and profitability. And I mean, we'll go into each little thing. The adjustability is, we've kind of, remember when we used to do lens implants, any other premium IOL, we actually do a lifestyle assessment with a lifestyle questionnaire. And I still do that. You want to get to know the patient, know what's up. And then you put a lens in, and that's what you get. The heel. And then if you miss the target, now I got to do a laser vision correction or PRK. I missed the target. They're not happy. And so now we do a lifestyle verification. So we actually put the lens in, let them live with it, let them heal, and then we do an adjustability to get them the outcome they need. So that's really what light adjustable lens is about.
Now, there have been some real changes. I know that a lot of us were concerned. There were a lot of things that the patient had to do. Post-op had to be careful about this. Tell us about that and what's different.
So that's my invisibility kind of thing. Is they have the active shield now. It's a built-in UV protection in the lens. And the beauty of that is, before active shield, the patients would have to wear 24/7 inside or outside special UV protective glasses, so you wouldn't polymerize or photopolymerize the macromers that are in the lens too early and cause a poor outcome and have to have an IOL exchange. Now we have active shield, so that rarely happens. And now patients only have to wear these UV glasses when they're outside until they get the final lock-in treatment. So the inconvenience in terms of patient is not there anymore. And really, patients like these glasses. They kind of look stylish. And people, their friends go, "Hey, what are you wearing those for?" And it kind of helps the word of mouth process.
So there's some extra visits involved here, and it's got to be worth it to you and the patient. Tell me how the patient benefits. How are you seeing the patients reacting to this, and what are examples of how this benefits them?
So, we tell patients that, I mean, in my opinion, every patient's a candidate for this. At first, a lot of people think, "Oh, just do it on the post-refractive patients because they might not be able to be enhanced." And I look at it like every single patient who's considering a premium upgrade qualifies for this technology. And we do a lifestyle assessment with them. We want to make sure, they are candidates for a premium, make sure there's no other pathology in the eye that's going to give them a poor visual outcome. But assuming there's nothing really, keratoconus or some weird thing going on in the eye or some poor macular disease, really almost every single patient is a candidate for this technology. And so the way it works is, we do the pre-op evaluation, get all our measurements, and then they see our surgery scheduler, and we close them out and get them involved. We give them information about the technology and the cost, and they see our scheduler, get booked, and then they have the surgery. We do one eye at a time, typically a week apart, try and get them treated as quick as possible. Make sure you kind of know what their dominant eye is versus non-dominant eye. It's kind of important with this technology. And then about 17 days later, as long as everything's healing properly, we do the first adjustment. And it depends kind of how we target them initially, which I can go over. And then if they're happy with the first adjustment, 3 to 4 days later, depending on the schedule, we kind of set days in our clinic. We call them LAL post-op visits. We know how long they take. We have to dilate patients to treat them with the LDD device. So as long as you arrange the schedule, we kind of group them every 3 to 4 days. And then we do a second adjustment if we need it. And then we do have to do 2 lock-in treatments. So we tell patients it'll be 3 to 5 treatments on average, 3 to 4 treatments.
And is it like, as an example, are a lot of people wanting to be plano in both eyes? Are you able to experiment with mini monovision and say, what do you think about that? And they go, maybe just a little bit more. And then we come back. Is that kind of how I'm reading this?
Right. So blended vision is the most common approach. There is, recently there is some new commercial data from RxSight. They actually had 143 bilateral subjects, 21 practices. And in that study, it was great because 74% of patients were targeted emmetropia in one eye and myopia in the fellow eye, which for blended vision. And so we discovered that's what most of us who are using the LAL are doing. It's what I do. And the lens, as we know, has an EDOF effect, as we discovered. So in the end target, you kind of want them around plano in the dominant eye and about minus 0.75 sphere or so in the non-dominant eye. The average or mean in that commercial data was a minus 0.7 in the non-dominant eye. And patients don't even notice the difference. And they're reading like J2. I think it was about 92%, maybe a little more than that, read J2. And over about 87% of patients read 20/20 or better for distance with this combination. So it's not a true monovision. I mean, obviously, if somebody did monovision pre-op their whole life in contact lenses, this is really easy. Some of those people even want a little more near vision. But for the run-of-the-mill cataract patient, I start to get them, the plan is to target where they're plano and minus 0.75 sphere. And most of them are really happy in the end. The quality of vision is really outstanding.
Do you find you've got this guy, that's what you target, that's what you got, and he ends up saying, I'd really like to see near a little bit more, and you bump him up to maybe 1 1/4, and he says, yeah, that works great, and then you can lock him in. So you've got that option of, or if he says, oh, shoot, I don't like this difference at all, just give me great distance vision and move on.
Yeah, I've had a variety of patients. I've had a couple of people who came to me just when my first actually LAL patient just wanted great distance vision. He was like a hyperope with up to 3 diopters of cylinder. Mm-hmm. And you have to set the expectation because we're not correcting the cylinder right at first. Okay. So you have to let them know they're going to have, it's going to be a couple weeks or so that I can correct your cylinder. You got to set expectations, but then you nail it. I mean, it's not like laser vision correction, PRK, or SMILE. There's healing involved with those and an extra procedure. There is no extra procedure. It's a 90-second LDD treatment with their eye dilated. My one patient that I did the first treatment on, I remember, he called me from his car with his eyes still dilated, literally an hour and a half later, saying my vision is the best I've ever had in my life.
Yeah.
And it's like you don't have to wait like till the next day or a week later for some healing from a laser vision correction to get it right on. So it's pretty amazing. It's kind of like that was kind of my aha moment. I think we were going to talk about that. Was that guy calling me with his eyes dilated like an hour later?
That's cool. So what's the biggest impact to you? I mean, as you're in your practice, it's obvious how this could affect positively patients, you guys.
Yeah. I mean, I just feel now that, I can really customize treatments for patient. I have the confidence that I know I can deliver the outcome that they want.
Yeah.
Give me that superior optimized outcome. I don't have to worry with healing as much now. And all those other variances, I'm like, oh, am I going to have enough tissue to treat them? And you don't have to worry about that. This lens works for pretty much everybody unless they have some other comorbidity that would prevent them from seeing well. And you don't get the poor quality of vision side effects. It's essentially a monofocal with some EDOF effect, and you're nailing the target very easily post-operatively.
So you're seeing yourself drift further and further away from multifocals in general.
I know, it's amazing. I would say out of all my premium IOLs, this is at least 85% of my premium IOLs now.
Okay,
and
that
so
blows me away. I didn't expect to hear it be that high. That's amazing.
I know. I mean, I keep going more and more LAL because it's like, honestly, it's very rare. You can't say you never have anything, but it's extremely rare to have an unhappy patient with LAL. And with multifocals, nothing against multifocals. I put them in, they get good outcomes. The problem with those is they get some dysphotopsias and glaring halos at night and some other poor quality of vision side effects to get that outcome. I feel with the LAL, I don't see that.
Well, and besides that, if we're off with the multifocal, we're still off.
And you're still off. You have to do some type of laser vision correction, a smile, some other procedure, which patients usually don't like that.
Okay, so there's no doubt there are people like me who've been on the fence about this, and although I'm getting off the fence the more you talk, what do you say to all the people who are out there? I don't know, man. It just seems like it's a lot more involved. I'm sure I got to get some sort of laser. What's your pitch to them?
Well, it's you're going to remain profitable with this if you're worried like my overhead's going up, but you're going to convert more patients. Okay. Bernie Haffey had a great economic impact study I presented at ASCRS, at the last ASCRS, on behalf of this technology. And, a third of premium IOLs, toric IOLs, a third, and a third of monofocal, you upgraded that many more patients to this technology that you never thought you could, because it's essentially a monofocal with a premium outcome. And
I mean, it makes sense, and just psychologically, I'm sitting here thinking about that patient in the exam room. I'm much more likely to say, listen, this really is that good, and I mean, I don't know if you use the word guarantee, but I can pretty much guarantee you a certain outcome. We couldn't do that before.
Yeah, the confidence, patients can tell I'm more confident, which is important. And I mean, I have a fellowship program. My fellows can talk to them about it. And all my fellows have brought this technology now to the practices where they're going. So, I mean, they've seen the benefit of it. I mean, ultimately, I just tell patients you're going to get a full range of vision. You're going to be able to, most people care about, what do they care about? Driving day and night and their smartphone. So, and even maybe working on their laptop. And I say, I'm going to be able to get you that full range of vision. I'm going to get you that superior quality of vision without the side effects. Might be a couple more visits. You set expectations like anything else, as long as you set expectations. But I always call this good chair time.
Yeah.
The other is bad chair time, when you have to talk people off. They're 2020, but they're not happy, even though they're J1 in 2020. This is their 2020 J1, and they're happy. The extra chair time I had to deliver to get that outcome was good chair time versus the bad chair time of some of the other technologies when you have an unhappy patient. And don't get me wrong, I use the other technologies. Not every patient's unhappy, but we know those patients, we get them. With this technology, you don't get the bad chair time.
Yeah, I just, so many of my patients are coming to mind right now. So, is the price point to the patient similar to what it was with multifocals in your practice and in most practices, or is there an upgrade beyond that?
No, I mean, it's pretty much, I mean, we just, we tell them about the upgrade, and we give them the information, we give them the cost, we tell them about the technology, we tell them, the extra visits, and we tell patients on those treatment visits, they can come and drive on their own. We're just dilating their pupils. It's right. I mean, they're wearing their UV protective glasses if it's a sunny day, or their clear ones if it's a cloudy, rainy day. They all can drive home. They only need a driver the day of surgery. That's it.
Okay.
Just like, if it was any other lens implant.
So somebody's, you're listening to us now, and we're all part of this. What does someone do? They go, okay, I need to know more about this. I need to find out what all is. I need to get down to the nuts and bolts of this. What do they do? Who do they talk to?
Well, I know, RxSight is the company. There's a website. I don't remember the web. I think it's listed here on the chat, www.rxsight.com/US. They can go to social media. They can reach out to me, my website. I can direct them. Anybody's welcome to visit me, do the procedure. and see LDD treatments. A lot of us out there throughout the U.S. are already using this technology, and it's growing rapidly. The amazing thing is, for example, patients don't even realize this technology exists. Never mind. And a lot of their eye surgeons they go to or eye care professionals don't even offer this option. And I was sitting at dinner last night watching some sports at the bar, and we're finishing up dinner, and a guy sitting next to me knew overheard I was an eye care professional, and he had been to somebody and they said that he had to use a specific lens. And then I said, no, I use that lens too. But he said, well, what do you think? Is it going to work for my eyes? I go, I don't know. You have to come in. I said, but we offer all the lenses. Right. And I told him about one of my favorites right now is the light adjustable lens. He goes, I never even heard of that. So it's amazing that it's, you know, it's getting more known, and doing these type of programs are getting the word out to our eye care professionals out there.
Yeah, I would have to say without question, I've not had anyone ask about it. So yeah, odds are if you start doing this, you'll be the new kid on the block.
It's a good thing. Yeah. You're going to get real busy. You're going to have to get a fellow to help you with your treatments now.
Oh my goodness. Yeah, I'm just going to turn it over to my son.
There, yeah. So, oh yeah, he's a beast.
Yeah, it's crazy. So we're about out of time. Any closing comments you got?
Well, I would consider LAL. It's for every type of patient. Don't think it's only for like post-refractive patients. I use it on every patient. My goal, you know, you get a full range of vision for most activities that we care about. You get superior quality of vision without the side effects, and it's really good chair time in the end with this technology, with happy patients and optimized outcomes.
And you know, as we get better and better at looking at the retina with OCTs and things, I see all kinds of people with just some early drusen. We didn't even notice it on the exam. Of course, they've got a cataract too.
Right.
And there would be nothing, you know, I'm really nervous about putting any type of multifocal implant in anyone's eyes that has any pathology. But this would actually be something you could do for someone who wanted it. As long, I'm not talking about severe AMD, but just real minor changes, a little hint of a problem, it'd be okay to use it.
Yeah, we use this in patients with, you know, early RMs and mild AMD changes. And we tell them, you know, they might progress, and then they're going to have to address, you know, things might change, but it's still a monofocal in the end with good quality of vision.
Yeah, they may lose some of the benefit, but they didn't hurt themselves. So,
but didn't hurt themselves. We're not splitting light. So,
okay. Well, I think we're done for that. You've been very helpful. This has been very enlightening for me. I appreciate it very much. And thank you, Mitch, and thank all of you in the audience. We appreciate you guys being here and putting up with us talking. But I've enjoyed this, and I hope you guys have too.
Thanks, Larry. Hope to see you all at AO coming to my town, Chicago. Look forward to seeing everybody.
Y'all have a great evening.
Take care.